Fortunately, I don't think anyone missed anything. I just pretty much read off the introduction slide here, but I'll give you a second to reread if anyone missed any concepts that I went over. Sorry about that. Okay, so now we'll go into some of the pre-planning considerations that you'll want to take. So the first practice that is a very good thing to do when you're starting a VMAT treatment plan is to do a target structure review. And some questions to consider for target volumes include, do the targets look reasonable? Obviously, as physicists and dosimetrists, we're not trained to delineate or outline target volumes. However, because of our clinical experience, we have a lot of familiarity with what they normally look like. So things that we're looking for that may be a mistake include stray pixels, missing slices, or discontinuous volumes. So if we see anything like this, it may be best to stop and just confirm with our radiation oncologist that the target is drawn correctly, because that will have a large impact in our planning approach. And if a 4D CT was acquired for the patient as part of their simulation, was an ITV generated. So in the picture here, I have an example of a lung tumor where you can see the pink volume is a GTV, but this patient had a 4D CT acquired as part of their simulation, and the physician drew an ITV, which encompasses that GTV on every phase of the breathing cycle. And then the red is obviously our PTV, which expands off the ITV. We're considering whether the PTV expansion is appropriate. Again, this is something that the radiation oncologist will usually define, but as physicists and dosimetrists, we know that generally it's approximately 1 millimeter expansion for SRS cases, approximately 3 millimeter expansion for head and neck and brain, and then approximately 5 millimeters for others. And finally, are there any SIB volumes? So SIB means simultaneous infield boost, or are there any boost volumes, sequential boost volumes? So we're wondering if there are going to be different dose levels that we're treating different targets to, because this will affect our plan approach, especially if it's a multi-phase treatment where there's an initial portion and a boost portion, because then we'll have to decide how to distribute our dose per plan. Do we want to try to cover the target fully in the initial plan and sacrifice target coverage in the boost to spare OARs, or do we want to split it more evenly? And this again would be a discussion with the radiation oncologist, but something that we want to consider before we start our plan. Next, we want to review nearby OARs. And the first question we'll ask is, are the OARs contoured accurately? And some important ones to focus on include brainstem, optic nerves, and chiasm, esophagus, duodenum, or any other critical structures that may be close to our PTV. And it's also good to check any fusions with other diagnostic imaging as well that may have been used in contouring. And this is important because in VMAT optimization, it's the way that the dose shaping will be performed is based on the contours, not the actual anatomy of the patient themselves. So we want to make sure that the contours are defined correctly and represent the true anatomy so that we're sparing the exact areas that we want to be sparing. It may be good practice to make some of your OARs high resolution. So most treatment planning systems have this option to make a contour high resolution, and this just provides more detailed, higher resolution data on the dose that structure is getting. And this is typically most useful for small structures, like any CNS structures close to the PTV, to make sure that if that structure exists near a very sharp dose gradient, that we're picking up any potential max dose that could be missed in a larger resolution. And then next, you can ask if any PRV structure should be created. So in some situations where OAR constraints are very high priority, like in the spinal cord or optic structures, and there is greater uncertainty in daily reproducibility of OAR position, like the bowel, stomach, etc., it's good to use PRV structures, which are just an expansion off the true structure. And finally, are there any OARs in close proximity or overlapping with the PTV? And our philosophy is to always prioritize fully covering the PTV, so receiving 100% PTV coverage, unless specifically noted by the physician otherwise. So unless the physician is communicating that, or as part of your clinical practice that you want to prioritize sparing a certain organ at risk over covering the target, you always want to try to cover the target 100%. And if OAR sparing is a priority and trade-off is needed, this may be a discussion with the physician, and this is where we want to start creating optimization structures and cropped OAR structures to use an optimization to achieve a desired balance between coverage and sparing.
And I
then
just wanted to pause
finally,
here real quickly, Brendan, if that's okay.
Yeah.
Just wanted to reiterate, these are great concepts, Brendan. I really appreciate it. One concept I wanted to reiterate was the image fusions and use of imaging. And so something really important, some hospitals utilize it a lot, some not as much. But imaging, if you think about it, it's what, like Brendan said, it's what we use to actually contour, and the contours are what are used for planning. It's also what we use to treat the patient. And so looking at all of your imaging and seeing what's important in terms of organ at risk motion, movement, are there preferable phases? If there's a 4D, are the fusions accurate? Are the fusions appropriate, right? So you wouldn't want to fuse, say, something that's moving in a free breathing CT because you don't really know what phase it is in a free breathing CT. So these fusions and imaging, it's really important to really take time to consider it as a department. And I've got one slide in here. One question, Brendan, I'll ask you, what PRV do you use? Is PRV equal to PTV? So what's the difference between PRV and PTV?
So PRV is usually only for organs at risk, but it's a similar concept to the PTV. So you may expand off of your organ at risk to protect it a little bit more if there's greater uncertainty in where the position of that OAR may be. So the examples that I give here are bowel and stomach. So those can fluctuate a little bit on a day-to-day basis. And if you're really trying to prioritize sparing the bowel or the stomach over an OAR, you may want to expand off of how the structure looks on your on your CT scan, because the position of the bowel and the stomach may change on a day-to-day basis. So that expansion is really anatomy dependent, and it's something that you may want to discuss with the physician on a patient by patient basis, because it really entirely depends on what organ you're considering and how much it's likely to move for that given patient.
Thanks so much, Brendan. You can go ahead.
Great, thanks. Okay, and just a few other pre-planned considerations. These are a few other dosimetry resources that I've linked in my talk. So when we upload these slides to the RCC drive after the presentation today, feel free to click through some of these other links, which will take you to documents related to other dosimetry guidelines. So that includes a plan quality checklist, which is something we've put together for physicists and dosimetrists to evaluate the quality of a plan after it's finished. Some standard naming conventions, which is a very good practice to have. Standardization really helps improve safety and efficiency. And then beam angle and collimator selection. So this is something that we've put a lot of work into our clinic. For different treatment sites, we've defined certain beam angle and collimator rotations that we use as a template. So on a pretty standard basis, if we have a prostate plan or if we have a lung plan, we'll use the same arc geometry and collimator rotation. And so that works for most cases. For some specific situations, you might need to adjust, but it's a good way to have a starting point for a given treatment site. So feel free to look through any of these resources after the talk today. And then also some guidelines for special situations. If the PTV extends to the surface, you may want to consider adding flash to your VMAT plan. If the patient has a implanted electronic device, you'll want to make some additional considerations in your planning, especially with what energy you're using and how you avoid delivering any dose to that electronic device. And then finally, if there's any high density material in the field, there may be some additional considerations that you take before you start your plan. All right, so with that all being said, I'll start to get into some of the basic principles of the treatment planning method that we'll talk about today. So first, I'd like to discuss some fundamental dose fall-off principles. And this is important because dose fall-off is very predictable for a given target size, distance from the target edge, and size or amount of OAR that needs to be spared. And for your typical standard fractionation case with the average size PTV, the maximum fall-off for sparing of a very small OAR volume is about 10% per millimeters. And it's important to understand that this is not achievable isotropically around the PTV. So you can't achieve this everywhere around the PTV. However, you can achieve it around a very small area. And so if you push the dose fall off around this very small area, it will likely spill out more in another area, but we have the ability to control where that dose spills out, and we can ideally have it spill away from critical structures. So I have this simple picture here on the right, a PTV and an OAR. So basically we know if we want to fully cover the edge of the PTV here and spare the OAR here, we know at very short distances, we should be able to achieve about 10% fall off per millimeter away from the edge of the PTV. So if we're getting 100% dose coverage to the edge of this PTV, and this OAR is 2 millimeters away, we should be able to drop the dose by about 20% from 100 to 80% here. And then when it comes to average dose fall off around the entire PTV, that will be approximately 3 to 5%. So like we said in this example, if you're really pushing the dose fall off here to 10% per millimeter, it's likely going to spill out more in other areas, and it may bow out here or here. But if you're just trying to contain the dose around the PTV uniformly, you should be able to achieve this 3 to 5%. Dose fall off does get progressively worse the further you get from the PTV. So if you're about 3 millimeters from the PTV, the max dose fall off should be about 85% of the prescription. So that would be that 5% per millimeter, right? Because if we're 3 millimeters away times 5% per millimeter, that's going to be a 15% drop in dose. And then at 1.3 centimeters from the PTV, the max dose fall off will be 65%. So you can see the dose fall off from 3 millimeters to 1.3 centimeters is only going to be 20% or 2% per millimeter. So as you get further from the PTV, that dose fall off flattens a little bit. It's not quite as sharp, and you can't achieve quite as severe of a dose fall off. But these principles are important to understand because it gives us an idea of what is achievable in terms of fully covering the target and sparing the organs at risk around that target. And then for SRS and SBRT cases where the target volume is much smaller, and we often allow a larger hotspot in the center of the target, we can make dose fall off even sharper. So for very small brain metastases, dose fall off can be up to 20% per millimeter isotropically. If the SRS target volume is a little bit larger, that dose fall off may be 7 to 8% isotropically. But you can see that's more than 2 times what we can achieve in standard SBRT cases. And for typical SBRT volumes, so in the lung or in the pelvis or other sites, the dose fall off can be up to 15% per millimeter for sparing of small OARs. So these are important rules of thumb to remember when you're planning an SRS and or SBRT case, that you're actually able to achieve an even sharper dose fall off so you can fully cover the target and spare nearby OARs even better if needed. Okay, so now that we have these dose fall off principles in mind, we'll consider starting to create optimization structures. So if you do have a situation where you have a PTV that overlaps or is in close proximity with a critical OAR, and when I say critical OAR, that means one that you want to prioritize higher the sparing of that OAR than the coverage of the target. We need to create manual optimization structures to achieve the optimal coverage and dose fall off during optimization. So the first structure that we'll talk about is the ZPTV opti. So this is the physician-defined PTV cropped back from any nearby or overlapping critical OARs. And again, those are OARs whose constraints will take priority over coverage. Or we will crop these back from higher dose PTV volumes in simultaneous infield boost cases. So if we're treating 2 targets, one to a higher dose level and one to a lower dose level, and those 2 targets overlap, we'll want to crop away the lower dose PTV from the higher dose PTV. And for small PTVs, this structure may need to be changed to high resolution to make sure that the cropping is accurate, because another thing that high resolution structures will do is it will better shape the adjustments to your structure if you're cropping away from very small organs at risk, like optic nerves or chiasm, something like that.
And Brendan, I'll stop you here just for a second.
Sure.
You go back one slide, mine. So these are all really important points. Yep. And this will become more clear as the presentation goes on and we start seeing some pictures shortly, but definitely want to focus on this idea of critical OARs. So like Brendan was saying, critical OARs, organs at risk that take priority over your PTV, so something like a spinal cord or optics or something like that. And because we have these concepts of knowledge of dose fall off, the idea is to predict it. And we want to predict it in such a way that you can crop this PTV a certain distance away from OARs. And by doing this, if you know the minimum distance that you can crop, it makes for no conflicting arguments in your optimizer. So whatever optimizer you're using, if you don't have conflicting arguments, it works really well. And so by optimizing to a cropped back PTV from an organ at risk that you're sparing, you're able to spare the organ at risk and get full coverage, basically 100% coverage to this cropped PTV. And if you get full coverage to the cropped PTV, you get maximum coverage to your general PTV. So really important concept, just wanted to reiterate it. Thanks for Brendan for letting me interrupt.
Great, thank you. Okay, so let's take an example here of a ZPTV opti and apply some of our dose fall-off principles. So if you do have an OAR that has a higher priority max dose constraint, you'll want to calculate the percent difference between the PTV prescription dose and the max dose constraint of that organ at risk to determine how many millimeters you need to crop back your PTV. So say you have a PTV that the physician has prescribed to receive 70 gray, and you have a nearby OAR with a max dose constraint of 45 gray. So the percent difference of those two will be 70 minus 45 divided by 70, or 36%. So there's a 36% dose reduction from 70 to 45. And if we're able to achieve a 10% per millimeter fall off for small volumes, 36% divided by 10% per millimeters, we need to crop back our PTV by 3.6 millimeters from that OAR to make sure that we can adequately spare the organ at risk while still covering as much of the target as possible. And another example is if the PTV of interest is a lower dose PTV in a simultaneous infield boost case, crop back the lower dose PTV from the higher dose PTV using the same formula. 5 millimeter or 5% per millimeter would be a reasonable estimate, as we don't need as sharp of a dose fall off between PTVs. So let's say we have a PTV low, which is prescribed to 54 gray, that overlaps with a PTV high prescribed to 70 gray. So the percent difference between those two is 23%. And if we can achieve 5% per millimeter fall off, then 23% divided by 5% per millimeter is a 4.6 millimeter crop. So we would want to crop back the PTV low from the PTV high by an additional 4.6 millimeters. So now I have a picture to just get an understanding of what that might look like. So here's an example of what a ZPTV opti may look like after you perform all of these calculations and crop back the structure appropriately. So in green here, or sorry, in blue, let's start with, is our PTV low. And our PTV low overlaps with an OAR with a higher max dose priority constraint in red, and it overlaps with a higher dose PTV. It also overlaps with this yellow structure, which is has a mean dose constraint, but that mean dose constraint is not higher priority than our coverage, so we're not cropping back from that. However, we do crop back the PTV low from the OAR with the higher priority constraint, and the distance that we crop back from is based on this calculation that we just did. So say this OAR in red has a max dose of 45 gray, then we want to crop back by 3.6 millimeters if the prescription to this is 70 gray. It really depends on the prescription dose to the target and the constraint. And then similarly, we crop back the PTV low from the PTV high so that we're not giving the optimizer conflicting arguments like Adam was saying, where we want to cover this area with 54 gray, but we also want to cover it with 70 gray. So when we crop this back, we just make it very clear for the optimizer, this area in green should be receiving the full prescription dose of this PTV, which is 54 gray. And then this PTV can receive the full 70 gray, and there's no conflicting information given to the optimizer. Another structure that we found that's very helpful is the ZPTV Opti rind. And this is a 5mm rind around the edge of the ZPTV Opti, which allows the optimizer to focus in on this area around the edge of the target and ensure adequate coverage of that area. So sometimes you may notice that the edges of your PTV are a little bit cooler than the center, and that may just be because the optimizer struggles to cover the periphery of the target. So this helps the optimizer focus on that area a little bit more and ensure that we're getting coverage all the way out to the edge of the PTV, or the ZPTV Opti in this case. Next, we'll go over a few ring structures. So ring structures help confine the dose to be only around the PTV. So basically, we're trying to limit how much dose is spilling outside of the PTV. And the way that we create these rings is based on, again, the principle of our fall off around the PTV. So the first ring is called the ZPTV Opti Ring 1. And this is a 1 cm thick ring that's 3mm away from the PTV. And the goal is to have this ring contain the 85% isodose line. So like we said before, it's reasonable to achieve approximately 5% per millimeter fall off isotropically around the PTV. So if we multiply 5% per millimeters times 3mm, which is how far away the ring is, then that should be a 15% dose fall off. So that's why when we're creating this structure and using it in our optimization, we'll typically set the constraint so that 0% of this structure receives more than 85% of the prescription dose. And on the right here, I just give you a quick step-by-step way of creating this structure reliably. So if you start by expanding off of your PTV 1.3 cm uniformly, and then just crop it back from the PTV by 3mm, and then you should have, this ring should be easily created. So the next would be for the SIB cases. So when you have multiple PTVs, it's difficult to create a ring that's uniformly a uniform distance away from the PTV, because obviously the dose fall off from the PTV 70 will be different than the dose fall off from the PTV 45. So the concept of this ring is to contain a single dose level across all PTVs. So we're going to variably crop this ring away from different PTVs. And I'll talk about how we do that now. So first, we start by making the ring 3mm away from the lowest dose level PTV. And then the ring will be slightly further away from the next highest dose level, and then slightly further away from the next highest dose level. And again, we'll use this same 5% per millimeter dose fall off rule to determine the exact distance needed to crop from each of these PTVs. So I have an example here that I'll talk through and describe how we create this ring. So first, I start by calculating 85% of the lowest dose level PTV prescription dose. So let's say we have 3 PTVs. One's going to 70 gray, one's going to 54, and one's going to 45. 85% of our lowest dose level PTV will be 85% of 45 gray, which is 38.25 gray. And then we have to calculate this percent difference and fall off from the higher and middle dose level PTVs. So 70 minus 38.25 divided by 70 is 45%. So for a 5% per millimeter fall off, this ring needs to be 9mm away from the PTV 70. And then 45 minus 38.25 divided by 54, that's 29%. And 29% divided by 5% per millimeter fall off is 6mm. So this middle dose level PTV needs to be 6mm away from the ring. And then to actually create this ring, we'll create a composite PTV structure, which includes all 3 PTV dose levels in one structure. And then we'll start by creating a 1.3 cm uniform expansion around this PTV composite. And then we'll begin to crop back this structure from each PTV by the calculated amount. So we'll crop back the ring structure by 9mm from the PTV 70. So you can see the 9mm crop here. And 6mm from the PTV 54, and you'll see the 6mm here. And then 3mm from the PTV 45, which you can see here. So the thickness of the ring itself will be variable, and the amount that it is cropped back from each PTV will be variable. However, we can just use a single objective for this ring. And as long as when we're optimizing, we set a constraint so that 0% of this structure receives more than 38.25 gray, we can be containing a single dose level within this ring. And so you can see we're able to use just this one value of 38.25 gray because we calculated the fall off from each PTV to what it would take to get to that dose level. So this is really helpful in cases with multiple PTVs where you want to still contain the low dose spilling as much as possible. If you do have multiple PTV cases, you'll still want to use this PTV Opti ring 1, and this can be generated as a uniform 3 millimeters away from the PTV total, and the max dose constraint for this structure will be applied so that it's 85% of the highest dose level PTV. And this one is a little simpler. You can see this is 3 millimeters away from all PTV dose levels. And the reason is that the 85% of the highest dose level PTV in this example, 85% of 70 gray is 59.5 gray. So we can reasonably contain 59.5 gray around this entire structure because these PTVs are only going to 54 and 45 gray. So really this entire structure is just to contain the dose around the highest dose level PTV, because the one limitation with this ring, the Z ring SIB1, is that we're not really containing the high dose fall off from the high dose PTV, because this ring is so far from the PTV just based on how we've defined it. It's nice to also have this ring to contain the higher dose fall off close to the highest dose level PTV.
Yeah, Brendan, I'll stop you here again if that's okay.
Yeah, please.
So this is great, and what I'd like to stress to everyone here, there are a lot of equations, a lot of diagrams and pictures. So don't get overwhelmed by it. In all actuality, you'll see Brendan later in this presentation give a brief introduction to actually optimizing sort of live. And you'll see that the hardest part of this planning process is creating the contours. But once you actually get these contours created, as Brendan stressed throughout, there are no conflicting arguments. So whatever planning system you use, if you know exactly physics-wise what can be achieved and you create contours based on that, it becomes extremely easy to plan. So I think what we might do also is probably send later in the next couple of weeks, send some anonymized DICOM files with structure sets and CT, and we'll have finished structure sets and beginning structure sets. That way you can practice this concept and see if you achieve exactly what the structures are supposed to be. And Brendan will also share some other tools that he's created to help make this process even easier. So just wanted to stress to not get too overwhelmed by all of this. It's a little bit of a learning process, but once you get it, your planning will be incredibly easy and you'll get really high quality plans.
Yes, and I can say just from implementing this in our clinic, we've seen a huge improvement in our dosimetrist plan quality, even from the most novice dosimetrists that we have on our team. So the way that these rings help control the dose fall off and minimize how much dose is going outside of the PTV goes a long way in making a very good plan. So there'll be just a couple more rings that I'll talk about here. So the next one is the ZPTV Opti Ring 2. And this is only for single PTV cases, so not for cases that have multiple PTV dose levels. And this is a 1 cm thick ring expanded off of the ZPTV Opti Ring 1. And the goal is to have this ring contain the 65% isodose line. So if you remember, we talked about that 2% per millimeter fall off as you get further away from the PTV, times 10 millimeters is 20% fall off from the edge of the 85% dose that we're containing at the ZPTV Opti Ring 1. So it might be easier for some of you to understand this in picture form. So in blue here, we have our PTV. So we're trying to cover this with 100%. And then our first ring in yellow is the ZPTV Opti Ring 1, which we talked about. And we try to not have any of the 85% dose spill into this ring. So all the 85% isodose line should be contained within this ring. And then the second ring that I just described is the ZPTV Opti ring 2. And this is directly adjacent to the Opti ring 1. And this should contain the 65% isodose line. So we try to have no more than 65% of the prescription dose fall outside of this ring. And that's the way that we'll set the constraints for it in our optimizer, like I say here. And to create this ring, again, it should be a very simple process. So all you have to do is simply apply a uniform 2.3 centimeter expansion on your PTV or your ZPTV Opti structure. And then you'll crop out of the PTV and Z Opti ring 1. Sorry, that should say 1. So it should be kind of a concentric ring just outside of the Opti ring 1. And then the final ring structure that I'll talk about is again for multiple PTV cases. So it's Z ring SIB2. And this is a ring that's expanded out from the ring SIB1 by varying amounts. And the goal is to have this ring contain the 65% isodose line of the lowest dose level PTV. So it's very similar process. We follow to the math that we use to calculate the ring SIB1. So we first start by calculating the 65% of the lowest dose level PTV. So in this example here, the lowest dose level PTV is 45 gray. So 65% of 45 gray is about 29 gray. And then we calculate the difference and fall off from the other PTV dose levels. So 70 minus 29 divided by 70 is about 58%. And here we're using 2.7% per millimeter fall off. So this is kind of splitting the difference between 2 and 5%. So as we said before, when you're really close to the PTV, dose can fall off at about 5% per millimeter. But as you get further away, the dose fall off gets lower. So we're using a slightly more conservative dose fall off here, not quite as sharp at 2.7 per millimeter. And this calculates out to be 2.1 centimeters. So that means we have to crop back this ring from the highest dose level PTV, PTV 70, by 2.1 centimeters. And then for our PTV 54, after doing all the math, we need to crop it back, the ring back by 1.7 centimeters from the PTV 54. And then it'll be 1.3 centimeters cropped back from the lowest dose level PTV. And again, you'll create this structure using a similar formula. First, you'll create a PTV composite and then start with the ring as a 2.3 centimeter expansion around that composite structure. And then you'll crop back the ring from each PTV by the calculated amount. So 2.1 cm for PTV 70, 1.7 cm for PTV 54, and 1.3 cm for PTV 45. So again, we have this variable distance ring from each of our PTV dose levels, but we should be able to set a single constraint in our optimizer so that 0% of this ring structure receives more than 29.25 gray. So that's, again, helping contain the dose fall off in multiple PTV cases. And then one final optimization structure that I'll introduce is for PTVs that overlap with higher priority mean dose constrained OARs. So this is not as common. It's pretty rare that you'll have a OAR with a higher priority mean dose constraint than PTV coverage, but it does happen in some situations. So it's an important concept to consider. So we called this structure Z OAR in PTV number. And so what we do is we expand the ZPTV Opti into the OAR by progressively increasing uniform thicknesses. So here's an example of a parotid overlapping with a PTV target. And in this case, the physician has said, I want to prioritize the mean dose constraint on the parotid over coverage of the target. So what we've done here is we've created a ZPTV Opti that crops back from the parotid. And then we've created two OAR and PTV optimization structures, a Z parotid in PTV1 and a Z parotid in PTV2. So you can see how these structures expand off of the Z Opti PTV into the parotid by uniform thicknesses. So here's like a 2 millimeter ring expanding off of the ZPTB opti into the parotid. And here's another 2 millimeter ring expanding even further into the parotid. And you can continue to do this depending on how much overlap you may have between that mean dose constrained OAR and the PTV. And so the way you would use these during optimization would be to start by applying objectives for full coverage on both of these structures. And then if the optimizer is showing you that the mean dose constraint on this OAR isn't being satisfied, then you can reduce the coverage goals of these structures, starting with the largest numbered one, the furthest away from the ZPTB opti, until the mean dose constraint is being met. So say you start optimizing and you're trying to fully cover these structures with full prescription dose, but the optimizer is telling you the mean dose constraint for the parotid is going to be exceeded. You can start to decrease the amount that you're covering this area. So say you can drop this to only 50% of the prescription dose. And what that may do is it may end up leading to reduced parotid dose, and the optimizer may show you that the mean dose constraint is now being met. So you can continue to fully cover this structure. However, if after dropping the dose all the way to 0 for this one, you're still not meeting the parotid constraint, then you can start to drop the coverage goals on this structure. So this kind of gives you an iterative way to ramp down the amount of overlap dose you have between the mean dose OAR and the PTV. And so this can be a very useful tool to precisely control the dose in that overlap area.
Yep, if you could pause you just one more time, Brendan. Again, this is all great information. With this concept, so again, Brendan's talked about all this dose fall off. So let's say we're at a parotid, and so naturally, Brendan's already discussed that you've got maximum, 10% per millimeter fall off on a small organ at risk. So once you've achieved that, you get this nice sharp dip in your 50% line that's 5 millimeters away, right? 10% per millimeter, 50% at 5 millimeters away. That's as much as you can spare the parotid, but your mean dose still isn't being spared. So what do? You just shave off, one of these 1 millimeter, 2 millimeter sort of rings that overlap with your parotid. And what does that do? It shifts your whole 50% isodose line 1 or 2 millimeters, further into the parotid for more parotid sparing. You lose some coverage of your PTV, but that's the concept. You're just shifting where this, 5 millimeter to 50% isodose line is. So it's a clever concept you won't use too often, but it's available. Again, just wanted to stress about all of these equations so far. Again, all it comes down to are those few first simple rules that Brendan talked about. Small organ at risk, 10% per millimeter, a bigger organ at risk, closer to 5% per millimeter. Between PTVs, symmetric fall off, anywhere from 3 to 5% per millimeter. So those few basic rules, that's all that you really need to think about. And then the rest is just simple math. So if you know the rules, and then everything else is just math examples. And you'll see shortly, Brendan has made this even easier for you. He'll share an Excel sheet with you, which automatically calculates these for you with input of small or large organ risk and dose levels. So again, don't want you to get overwhelmed. If you pursue this and you master it, which I think won't take very long, your planning will become very simple with very high quality. So again, just want to reiterate, there are really only a few simple rules. The rest has just been mathematical examples by Brendan. So thanks, Brendan. You can proceed.
Sure. Yeah, and I will add to that it probably seems like a lot of setup before going into actually planning, but I think that it's an overall benefit because you can take all this time in the beginning to set all these structures up correctly and set your optimization up the correct way. And the benefit of that is you only have to run the optimization one time compared to if you don't use structures like this and you're just trying to guess at how much sparing you might be able to achieve. It'll take multiple runs of an optimization to be able to achieve that. So I think while it does seem like a lot, there will be a payoff in terms of saving time and creating a great plan if you just take the time to set this up and set it up in this way. So now I'll just list off some of the optimization objectives that we use for each of these structures. I won't really read through every single one of these since they'll be available to you and you can go back and reread them. But first we have the ZPTV opti, which will obviously have lower and upper objectives on. And the priority that we set for these is 120. Then we'll have a ZPTV opti rind, which we also will have lower and upper objectives on. This is that 5mm rind on the very edge of the target volume. And we also have that at priority 120. So this is for the coverage of our target, the rind and the ZPTV opti. And then for our ring structures, for the ZPTV opti ring 1, we'll just have a single upper objective, which will be 0% of this structure receives 85% of the prescription dose. And if you have multiple PTV cases, this will have 0% of this structure will receive 85% of the highest dose level PTV. And the priority we use for this structure is 80. And then if you have a multiple PTV case and you create a Z ring SIB1, 0% of that Z ring SIB1 will receive 85% of the lowest dose level PTV with the priority of 80. And remember, we talked about this. This is the cropping of this is based on the 85% level of the lowest dose PTV. So that's why we're using it for the objective. And for ring 2, it will be 0% receives 65% of the highest dose level PTV. And for Z ring SIB2, 0% of this structure will receive more than 65% of the lowest dose level PTV with a priority of 80. Then we'll use a normal tissue objective. I know this is a standard option in Eclipse. I'm not sure in other planning systems what this may be called or if this is always available. But basically, this is just an optimizer tool that looks at the area outside of anything that's been defined as a PTV. So anything in your optimization that you put a lower objective on, this normal tissue objective tool will try to contain the dose around that area. So it's working very similar to the rings that we've set up. And these are the normal settings that we use for our normal tissue objective. So the starting dose is 100%. So we're considering the edge of our PTV getting 100%, and then we want the end dose to be 40%. And the distance from dose fall off is 1 millimeter. And then it allows you to provide exponential factor. And we use varying exponential factors depending on the shape and the size of our target. And the priority that we'll set for this objective is 100. And then finally, for all of our OARs, so we start by having all of our OARs that have max dose constraints, we'll set 0% of those receiving up to the max dose constraint with a priority of 80. And then each OAR, this is a very important aspect of the planning technique. Every single OAR, even if it doesn't necessarily have a high priority objectives defined by the physician, will set mean dose objectives for all the OARs. And we start with that mean dose set just at full prescription dose, and we'll start with this mean objective priority at 0. And when we go through our demo today, I'll show you why and how we will adjust this during the actual optimization. And I can read through these. It may be more helpful if we just go to the demo because you'll actually be able to see it in real life. So maybe I'll just quickly skip through this slide where it talks about the style in which we manipulate the optimizer during optimization. And again, this slide also discusses that. So in the various steps of the optimizer, we're going to be performing different manipulations on the objectives to try to achieve the best dose distribution that we can. So that's all I have for now in terms of our slides. And unless there are any other questions that you think I could answer right now, Adam, I can just jump into the demo.
Yeah, can you maybe, are you going to show the Excel sheet next?
Yeah, I can do that.
Yeah, I think it would be great to show the Excel sheet and then maybe the demo right after. The Excel sheet, I think, would be really helpful to everybody.
Yeah. I was going to just show the target volumes and the slice, like the CT slices for the patient, just to kind of inform how we're going to set up the Excel spreadsheet.
Yeah, that sounds perfect, Brendan. Thanks.
Okay, great. So now I'm pulling over an example patient here. So you can see this is a prostate plus nodes radiation patient. And these are usually pretty large target volumes. And in this case, they're in a single plan. We're treating to 3 different dose levels. So here are 3 different PTVs. One's getting 70 gray, one PTV dose level is getting 63, and one's getting 54. So I can quickly just scroll through the slices here, and you can see the various. So the highest dose level PTV is the prostate itself. And then the surrounding nodes are the 50.4 gray. And then there's some nodes that showed up PET positive on diagnostic imaging that were boosting to a slightly higher dose. So you can see all 3 of those volumes here. And then a lot of these volumes come in very close proximity to the bowel. So here's our bowel bag structure. That this is basically a PRV that our physician draws. And it's because on any given day, the bowel could move in pretty much anywhere in this area. So the physician likes to be extra conservative with our bowel sparing and assume worst case scenario that the bowel may be in any one of these areas during treatment on a given day. And in this case, the physician has requested that the bowel doesn't receive any more than 54 gray. So the bowel constraint has a max dose of 54 gray. And we're still going to try to cover as much of the PTVs with full prescription dose as we possibly can. So with the optimization structures that we just discussed in mind, I created an Excel spreadsheet, which I can show you here. And I'll just quickly walk you through the Excel spreadsheet. So there's multiple tabs here at the bottom. This first tab is for cases where you only have a single phase and a single PTV. So let's say this case was a little bit simpler and we only had a single target going to 70 gray, so 7,000 centigray. So in this spreadsheet, I plug in the prescription dose in this cell. And then let's say we have some high priority OAR structures. So in this case, the bowel bag was that structure that the physician defined as higher priority. And the max dose constraint that the physician set was 54 gray. And next, it's important in this spreadsheet to define whether it's a small or large OAR. So small means that it only overlaps or is adjacent to a small percentage of the PTV. Large means that it's overlapping or adjacent to a larger percentage of the PTV. And this is important because, like we talked about before, dose fall off, you can only get a really high dose fall off over a small area. So the summary down here explains this well. If it's a small OAR, you can achieve that 10% per millimeter fall off because it's just a small area that you're trying to spare. However, if it's a large OAR, it's not as easy to have sharp dose fall off because you're trying to have the dose fall off over a greater area of the target. So in this case, the bowel would be considered a large OAR because it's overlapping with the target by a larger amount. And so this is what dictates our fall off here. And so you can see this number updated. When I type this number in, say I changed it to 40, this number updates with the distance that you need to chop the PTV back from this structure. So with our constraint at 54 gray, we need to crop back our PTV 70 by 0.46 centimeters, or about 5 millimeters from our bowel bag to be able to achieve full prescription dose and safely spare the bowel from this amount. So you can see built into this Excel spreadsheet are all the dose fall off principles, and it provides this single number that you can use to crop back your PTV from this structure, so you know exactly how much of the PTV you can cover fully while still safely sparing this structure. So if I'll hit reset here, that clears everything out. So again, I said that's just for a single phase, single PTV. But say you have a multi-phase or multi-PTV situation. So let me clear this out here. So let's say we'll use this example here where we're just treating in a single phase or a single plan. So it's one phase, but it's 3 PTV dose levels, right? Because we are treating PTV 70, 63, and 50.4. So, and then we have that same OAR volume that we want to spare by the same amount. So we have that bowel bag, that's a large structure that we want to spare by 54 gray. So next we would plug in our phase one. Since there's only one phase, we'll plug in our prescription dose for each PTV. So the PTV high is getting 7,000 centigray, the intermediate PTV is getting 6,300 centigray, and the low PTV is getting 50.4. And I'll walk you through now exactly how to read out this spreadsheet so you understand exactly which numbers to use. So we'll read it from left to right, from the top row to the bottom row. So first we'll start with PTV high. Now this will tell us in each column exactly how much we need to crop back PTV high from each of these other structures. So we don't need to crop back PTV high from itself, that makes sense. We don't need to crop back PTV high from PTV intermediate, and we don't need to crop back PTV low from PTV high from PTV low, because this is the highest dose level PTV. So we're not cropping the highest dose level PTV back from the lower ones. However, we do need to crop back the PTV high from our OAR1, which is the bowel bag here, by that 5 millimeters. So you can see the same number comes out here as on the first tab. So when we're creating our ZPTV opti, we're going to crop the PTV high back from the bowel bag by 5 millimeters. And then we can go through each PTV here and gain the same information. So for PTV intermediate, which is our 63 gray PTV, we're going to crop it back from the PTV high by 2 millimeters. And we're going to crop it back from the bowel bag by 3 millimeters. And then finally, for PTV low, we're going to crop back PTV low from PTV high by 6 millimeters. And we're going to crop back PTV low from PTV intermediate by 4 millimeters. And then this box explains the cropping distances to create those different SIB rings. So PTV high, we're going to crop the ring back from PTV high by 8 millimeters. And we're going to crop it back from PTV intermediate by 7 and PTV low by 3 millimeters. And then for ring SIB2, we're going to crop it, the high PTV back by 2 millimeters, or sorry, 2 centimeters. We're going to crop back the PTV intermediate by 1.8, and we're going to crop back from the PTV low by 1.3. So really, this Excel spreadsheet should do a lot of the math for you. In the background, it's taking into account all of those dose fall-off principles, and as long as you accurately plug in your different dose levels and your constraints, these numbers should come out to accurately tell you how much to crop back those structures from. So now if we jump back to our actual structure set, you can start to see some of those structures in work. So now let me unhighlight the 2 lower dose level PTVs and show you the PTV intermediate, or let's start with the PTV low. So you can see here, if I highlight the blue full PTV low and then our optimization PTV low, you can see that the optimization structure is cropped back from our higher dose level PTVs by that amount that we calculated, but it's not cropped back from the bowel because the prescription dose to this structure is only 50.4 and the max bowel dose is 54 gray. So we should be able to fully cover this structure with prescription dose while still meeting that bowel bag constraint. Now, let me highlight the intermediate dose level structure and the optimization structure that we created here. So again, we didn't actually need to crop this structure back from anything because it was far enough away from the bowel bag that we should be able to fully cover this PTV with its prescription dose and still spare the bowel. So remember here, for the PTV intermediate, we calculated that we need to crop back from the bowel bag by 3 millimeters. However, if our structure is already 3 millimeters away from the organ at risk, then we shouldn't have to crop it back at all. So you can see here, no cropping was actually necessary for this PTV because we were far enough away. And over here as well, you can see we were far enough away from the bowel bag to not need to do any additional cropping back. So all of these principles are coming into play for us to understand exactly how much coverage we can get while still sparing a structure like this. And then finally, for our highest dose level PTV, that one's also far enough away from the bowel that we didn't need to crop it back at all. So here you can see we have all our optimization structures set up, all the rinds. So you can see the PTV high rind is that outer edge of our prostate high dose target volume. And then we have rinds for the intermediate volumes as well, and then a rind for the lowest dose level. And then here you can see all of our rings. So this is the PTV Opti Ring 1. It's named a little bit differently here, but this is the Ring 1, which is supposed to contain the 85% of the high dose PTV. So that's 3 millimeters away from our full composite PTV. And then there's PTV Ring Opti 2, which is 1.3 centimeters away from our composite PTV. And this will contain 65% of the high dose level PTV. And here are our SIB rings. So because this is a multiple dose level case, we had to create some SIB rings. And so if I turn the bowel bag off, you should be able to see here that this ring is very close to the lowest dose level PTV. It's very close to that PTV 50.4. But then as we get down to the prostate, the highest dose level PTV, it's further away from this one. So remember, we have variable distances away from our different PTVs depending on what dose level they're at. So for the highest dose level, this ring will be the furthest away from the PTV. And in this case, that distance, remember we calculated it here, is 8 millimeters. So here we said that the ring SIB1 needs to be 8 millimeters from PTV high. And I can show you here, that's pretty much right what it's at. You can see it's about 8 millimeters from the edge of that PTV. And then a similar situation with the ring SIB2. So just containing that slightly lower isodose line of the low dose PTV. So yeah, once we've generated all these structures, then we should be ready to go into our optimization.
And Brendan, I think it might be helpful to just share the dose. So let's just turn on the PTVs and the bowel bag, for example, only,
Sure.
not the optimization structures. And let's just look at the dose for a second, just to give people an idea of, exactly what we're expecting. So if you look at like the 100%, or 100 or 95%, 105% for each dose level. So
Yeah.
noticing that by separating PTVs with that margin, you can control the 105 in each dose level, the general dose fall off, and noting to everyone, because we spent so much time on these contours, this plan only took Brendan one time. So he didn't have to do multiple iterations. He didn't have to add extra planning structures to help. It took one try and he got this plan. So
here I'll show you the 95% isodose line for the low dose PTV. So this is a 95% of 50.4 gray. And you can see how conformal the isodose line is with the structure itself, how the coverage is very homogeneous and uniform, and how there's really not any hot spots outside of those higher dose level PTVs. So look at how well it's shaped on the structure. If there is any dose spillage, then it's going to be away from our critical structure. So you can see there's a little dose spillage here, but it's not going into any organs at risk. It's avoiding the rectum and the bowel here. And it's really just shaping the dose in the most optimal way possible. And so here I can show you down near the rectum. Let's go to, let's say, 95% of our highest dose level PTV, 6650. So again, you can see how often the most concerning OAR down here is the rectum. So here we can see how well we're able to cover the target with at least 95% of prescription dose and spare the rectum. So it's really a perfect balance where we're falling right on the line of the PTV and just covering it enough while maximally sparing the rectum dose as much as possible. That's all thanks to the way that the optimization structures were created and the way that the plan was optimized. The only other thing I can think of, I can go into contouring and either manually show how to create the structures or show our auto contouring. I don't know if either of those would be useful.
I think maybe, Brennan, if you could just open up the example plan and just do just a step one optimization, just to show the general concepts of optimization. So the starting objectives and the general concept of optimization. Again, we'll have more resources to publish online soon with full examples start to finish, but this will give you a good idea of, once you have the contours, the exact starting optimization objectives, which are also in that Excel sheet, and then the thought process that Brennan will do in optimizing.
Yep. So yeah, and anyone who's practicing creating these optimization structures is welcome to reach out, and we're happy to help. It takes a little bit of practice to get the hang of it if you're going to be creating them manually. But really, since it's the same process over and over, if you do practice a little bit, it becomes much more familiar and it becomes much more of a routine. And it's a lot easier after a few cases. So give it a try a few times and the rules should come easier to you as you continue to practice. So now that we're in our optimization window here, you can see I already have all of our objectives set up. So I have all of our upper and lower objectives on our ZPTV opti structures and our ZPTV rind structures. And then for each OAR, I have a max dose constraint, which if there's no max dose constraint defined by the physician, I'll usually just set the max dose constraint to be about 103% of the highest prescription dose. So this is 103% of 70 gray. And then I have mean dose objectives set up for each structure as well, with no priority setting at this point. So if I go through here, the only one that I would want to have an upper objective with any meaningful max dose constraint is the bowel bag, because the physician said that no more than, 0% of the bowel bag should receive 54 gray. So the max dose of the bowel should be 54. So I have that set. And then I have all of our ring structures set up with the Z8 PTV Opti Ring 1 will be 85% of our highest dose level PTV. ZPTV Opti Ring 2 will be 65% of our highest dose level PTV. And then ring SIB1 will be a max dose of 85% of our lowest dose level PTV. And ring SIB2 will have a max dose of 65% of our lowest dose level PTV. And those have priority 80. And then we have our normal tissue objective set with the settings that I described in the slides. And now if I get this started, we can start to show you some of the technique that we use during optimization to achieve the best plan. So
and just to reiterate, all those objectives that Brendan has listed, those are also automatically input into the Excel sheet for you.
Yes, so while we're waiting for the optimization to start, I can show you here. In the Excel spreadsheet, all those objectives come out right here in the next tab. So you can see exactly how to set each of those optimization objectives. And every optimizer may work slightly differently, but the general idea of the optimizer is that it starts at a very low resolution. So it's using only a few control points. And so right when the optimization starts in the first level, I hit pause. And you can see here, let me highlight the structures of interest. So let me highlight all of our PTVs, which are starting to reach their coverage objectives, and same with our PTV rinds. And then let me show you the rings. So the rings, just take note of the shape in the beginning. They'll likely look something like this. You will not be meeting the objectives exactly. This is just a goal that we push the optimizer to achieve, but it's never actually going to achieve this fully. But the shape of the ring DVH should look pretty much like this. through the entirety of the optimization. So really the shape of these ring deviations shouldn't be changing. The amount of that we're controlling the dose fall off uniformly around the target shouldn't change. So now once the optimizer has had a second to kind of reach a good initial solution, then what we do is we start to manipulate the mean dose objectives for each OAR. And so I'll start to do this by first noting the value that the optimizer first reports the mean dose at, and trying to set this to be about 4 gray less. So then I'll set a priority on that objective to about 80. And then I'll continue to do this for each OAR. So I'll iterate through each of the OARs. And so this is at 800. So let's say maybe 500 I can set as a starting goal. So around 300 to 400 centigrade less than what the optimizer initially reports. So this one's at 600. So let's say 650. I'll set it to 350. This one's at about 30. So I'll set it to 27. And I continue to do this for each organ at risk that we've contoured. And you can kind of quickly go through this as you see the amount. So this one's pretty low already, so maybe I won't try to achieve too much sparing there. And the rectum will set to 31 gray. And now with each adjustment, give the optimizer a second to fall back into a more local minimum. So you can see the optimizer is working to reduce that cost. And as it's reducing, we can scroll back up to bladder and you can see it's already reduced the bladder to the amount that we asked it to. So now we can continue to push it, reduce by another 400. And this one hasn't been able to achieve the value quite as well as we had hoped. So we can leave it at 500 or maybe only reduce it by a little bit to 450. So you're trying not to have the goal be too much lower than the actual dose being reported by the optimizer, but just pushing it a little bit to see if you can improve sparing just a little bit to each of these structures. So you can see the bowel bag has reduced to under what we asked it to. So now we can continue to push down the mean dose. And then same thing here. We can push this down to 700. And this one we can push down to 700.
And a pretty good rule, I'm interrupting here, but a pretty good rule of thumb is if it achieves within 150 centigrade, if it's less than 150 centigrade away, your objective from your actual mean, then you can probably keep pushing it lower. If it levels out and it's greater than 150 away, it's probably not going to achieve it. And you probably don't have to push it much more. So 150 centigrade is typically a nice sort of general rule of thumb for a cutoff for mean doses.
Yep. And just one other thing to add, I'm not adjusting the ring structure objectives at all. So those will stay the same throughout the entirety of this optimization. So we will not touch those again. And we'll just continue to cycle through our different OARs. So see again now the bladder dose has gotten down to the objective that we asked it to. So we'll continue, sorry, 4,000. We'll continue to reduce that one. This one's about 200. So we'll maybe reduce that just a little bit more and see if it can come down. But like Adam was saying, it's not quite reaching that 150 centigrade difference. So we don't want to push it too much more. Same with this one. We're at about 200. So we'll probably leave that where it is. Bowel bag, it looks like we can keep pushing because the optimizer has reached the objective we asked for. This one we can push a little bit more, and we can push a little more. And then rectum, we can continue to push. See, rectum is reaching under 150 centigrade, so we can continue to push that a bit. And so basically what we'll do is for the entirety of the first level of optimization, which again may vary depending on the treatment planning system you have. But for the initial phases of the optimization, once we've reached, at this stage, once we've reached a point where we think we've gotten to the lowest we can push all the mean dose objectives, then we'll restart the optimizer and let it advance to the next stage, and then continue this process throughout level 1 and level 2, really just making sure that our mean dose objective is always pushing the mean dose down on each OAR as much as possible.
Yep, that's super helpful, Brendan. And so by the time that Brendan finishes, let's say he won't do any more because we only have a few minutes left, but by the time he finishes the whole optimization, most or all of the organs at risk should be about 150 centigrade less. The objective should be about 150 centigrade less than the mean dose, than the actual mean dose by the end of optimization. Your PTV shoulders shouldn't change. So again, if you just push to that point, PTV shoulders should remain about the same. And step 3, you can just sort of just barely fine tune some of the max organs at risk and some of the shoulders of the PTV. But you can see now, even all the ZPTVs, he has really good max doses right around 105%. His shoulders are close to full coverage. Again, he can perfect that slightly in step 3. And if he does the same concept of just pushing mean dose, making sure that it's about 150 centigrade when it levels out lower than the actual, then by the time he's done, he'll have a perfect plan and first try.
Yeah, and just the last thing that I'll show you here is I'll just highlight for this case that we're working on now, exactly how much reduction we were able to get compared to the clinical plan that was initially used for this patient. So a dosimetrist who wasn't using this optimization technique, just using a more standard way of optimizing, achieved this plan with the square DVHs. So you can see the squares here and here and here for each structure. And then the triangles is with our Shulman method. You can see how much reduction on the DVH for each structure was achieved by using this technique. So you can see how much rectal dose sparing we were able to gain and how much bladder dose sparing, bowel bag, and that's not rectum, that's large bowel. We were able to achieve for each of these structures just using approach. So
the cool thing
can really make a huge clinical difference.
And the cool thing is, this is a plan, and our dosimetrists in UC Health in Colorado Springs are honestly some of the best I've ever worked with. And so we're taking an excellent dosimetrist, one of the best I've ever worked with, that probably did many iterations, and we just did one iteration and see this drastic improvement. I've done comparisons with dosimetrists elsewhere, and sometimes you see a 50% drop in basically every organ at risk. So I really do think it's going to be a helpful tool for all of you.
Yeah, and we'll gladly provide all the resources that we shared today to hopefully make the process of using this technique as easy as possible.
Well, thank you so much, Brendan. I see a couple other questions in here. Maybe we'll answer just before we get off. Again, thanks so much, Brendan, for a really nice presentation, and thanks for developing a lot of these tools also. And that Excel sheet in particular is extremely helpful.